So kind of the background on our research project. So this research project is based out of Chattanooga, Tennessee, at Erlanger. Um, we have a team of pulmonary and critical care physicians and internal medicine residents that are on this project with me. I'm a third-year medical student at UTHSC based out of Memphis. But luckily, with our clinical rotations, I'm able to complete those in Chattanooga. So I was able to get on this project with our group in Chattanooga to work on this research. So kind of just a brief summary of what alpha-1 antitrypsin deficiency is. So it's a genetic condition that is inherited in an autosomal codominant manner, and that can cause early lung disease and liver disease in patients. How it does that is alpha-1 antitrypsin is a protein that inhibits neutrophil elastase, and neutrophil elastase, when uninhibited, can break down the body's own tissue and cause hepatocyte destruction or emphysema. And you see this this typically presents as obstructive lung disease in patients, especially in smokers at a relatively young age. So in terms of, what we wanted to study in this is we wanted to kind of figure out, when a patient has a diagnosis of alpha-1 antitrypsin deficiency, what are they, typically at risk for? We know that there's obstructive lung disease that is associated with this, but there's, most likely a lot more things that we need to be aware of that we can kind of educate our patients about. So in terms of this study, this is a cross-sectional study that involves almost, we have a large database with, we have 1,137 patients that have been recorded into our database, but I believe we have 1,200. So we're nearing completion of going through EPIC and, recording the information about all these patients. But this data was collected between a 5-year period, 2018 through 2023. And basically anybody who walked through the doors of Erlanger and had an obstructive PFT was genetically tested for alpha-1. And kind of how we grouped the genotypes of alpha-1 in this population. So is what we consider normal. This is typically somebody who wouldn't have alpha-1 antitrypsin deficiency. You would test positive, or you would test for But there are a lot of different combinations with the alleles. As a autosomal codominant manner, you have the normal M allele, but you can also have MS, MZ, SZ, SS, ZZ. There's a lot of different combinations. We typically focused on heterozygotes, meaning that they had one normal allele and one abnormal allele. But, keep in mind that there are other combinations out there, like that have two abnormal alleles. They might not be homozygotes, but, they're considered compound heterozygotes because it's like SZ instead of like ZZ. So it gets kind of, you can get kind of in the weeds with that. But for our study, these, what we defined as heterozygotes are patients with one normal and one abnormal allele. And we've been running the numbers. I know that whenever I first presented a research project on this topic, we had 100 patients. So we've been able to kind of see how things have been evolving with more data. Our last presentation, we had 752 patients. And, we've been getting significant data on certain elements, but we've been losing it after adjusting for smoking. So we were curious typically about if the MS genotype was driving us towards the null hypothesis. MS heterozygotes are typically associated with less severe disease. Most patients that do have MS as their genotype can actually have, an 80% normal level of alpha-1 antitrypsin detected in their body. So we were thinking, maybe if we are grouping the MS heterozygotes in the abnormal population, that actually is, conflicting our data. And so in terms of the data that we do collect to kind of, determine the risk factors, I kind of have this pie chart at the bottom, but we looked at their PFTs, their 6-minute walks, if they were available, if they had fibrotic changes on an X-ray or, a diagnosis of pulmonary fibrosis. If they were on ICS or a LAVA or a LAMA, that was recorded heart failure, AFib, non-alcoholic cirrhosis because of the association of cirrhosis with alpha-1, smoking, oxygen therapy, hospitalizations, and just their general demographics. But we also look at all-cause mortality. If the patient was deceased, that would have been a positive for all-cause mortality. So I include this chart here, and we have a lot of variables, but I kind of kept it simple. What factors were associated with pulmonary fibrosis and all-cause mortality in these patients? And our groups that we had here, so we had the MM and the MS combined together versus the abnormal heterozygotes, and then we removed MS altogether to see if there's any difference in this MS group that's affecting our data. And as you can see from both charts, we really didn't have any difference between the combined group and the removed group in terms of our significance. For the all-cause mortality, apologize for that siren back there, but for the combined group, we did not have, we had a significance between age and cirrhosis, and then for pulmonary fibrosis, there was a significant risk factor associated with age, male sex, and COPD. So kind of, as a conclusion and, also a discussion, we've been just experimenting with different ways to kind of analyze our data and try to figure out, what can we do with this large database of patients that we have, and how can we, format it in a paper in the future so that it can be used by professionals to help educate their patients. The MS genotypes, even though it's associated with clinically less severe disease, did not appear to be conflicting our data. And probably in the final paper, we will keep the MS genotypes with the abnormal heterozygote group. Yeah, that's kind of the main basis of this poster. And so moving forward, we're just going to kind of meet together as a research group and try to figure out the best way to get this down into a journal article.